I'm happy to introduce Andrey. Right here. Kormilitzin. Yes? Yeah, that. So Andrey is a group lead at the Department of Psychiatry at the University of Oxford. He's also a member of Oxford Mathematical Institute. Andrey's research is centered around applications of statistical machine learning, NLP, and the mathematics of multidimensional data streams can be applied to improve the detection, treatment, and monitoring of interventions in mental health. So thank you, Andrey, for coming here.
Thank you very much for inviting me and presenting. I'll try to stay to half an hour. First of all, welcome and thank you very much. And today I'm going to discuss one of our research that we do in our lab with our colleagues, psychiatrists and clinicians, is how to identify mentions of self-harm in clinical notes.
If you can just beat the center and talk more to the mic for this Kormilitzin.
Okay, beautiful. Right, and just following good tradition, I started by Ella's folks. I'd like to introduce what brought me here and my connection to mental health. So, thank you to the for introducing. I have a small research group in Oxford, and I spend my time between Mathematical Institute and Department of Psychiatry. I have a master, doctorate students, and postdocs working on the applications of data science and tools, computational tools applied to the wealth of psychiatric and mental health data. So I've been very lucky at Department of Psychiatry. I'm sitting on top of a pile of really amazing data, such as unstructured clinical notes, really massive clinical notes, structured fields, CT scans, imaging, time series, wearable devices, and so on and so forth. So it's really a treasure trove for data science in us. And what we do as a methodologist, we collaborate with clinicians, psychiatrists, nurses, and we're trying to answer different questions spanning a wide range of fields, such as using NLP to extract information from clinical notes for pathological analysis, working with children and adolescent psychiatrists on autism, longitudinal multimodal data analysis, and developing deployable tools, and of course working with patient and public involvement in order to make sure that our tools they make sense to people. Right, so the main topic in our discussion is about self-harm. So self-harm is defined as an act of a hurt or an act of self-cause or self-injury, regardless of its intent. So we do not care what was the main reason for self-harming behavior. We want to identify cases where people start self-harming or causing damage to their bodies. And self-harm is a really big problem nationally and across many, many countries as well. So self-harm, in some cases, self-harm leads to suicides, and based on national statistics in England, there are over 5,000 cases per year of people dying by suicide, compared to 400 in Israel, which is good. And many people who self-harm, they end up in hospitals. They've been admitted to hospitals, over 200,000 people every year, which of course puts lots of burden on the health system. And the main problem is not burden on the health services, but rather people who went undetected. So the majority of people, they simply do not seek help. And this is the problem, because these people, they just go undetected. It causes lots of stress and problems to their family members, their loved ones, and therefore, if we can help some groups of people, we can help. It will be great. I'm not a clinician. Do you have a question?
How many out of the 5,006 had before that?
Well, it's a great question. So let's discuss it later. Okay, I just want to. It's a good question to just come back. Okay. So I just jumped one slide. Right. So I'm not a clinician, so I cannot confidently speak about the reasons for self-harming behavior, but usually based on clinical literature, is to people self-harm to reduce a tension or a psychological distress. So I'm sure there are lots of psychologists in this audience, and you know guys better than me what may cause to self-harm. Usually this is the way how people can express themselves. Sometimes they punish themselves because they feel really miserable. They do not deserve good life or other problems. And the importance, it's needless to highlight the importance why we need to research this field, but at least some points is, first of all, is to develop tools to assess what's early detect potential cases or subgroups of people who are at high risk of self-harming behavior. If we can identify that, we can then intervene. We can identify such people and invite some clinical trials. So, for example, a company like MeDS or others, if you can find your target, perhaps you can invite and try different interventions early and see the outcomes. And of course, pharmaceutical companies, if there are any medication available to reduce emotional stress or help people. And from the research perspective, it's important to understand the prevalence of this self-harming behavior for epidemiological analysis. So the problem we're solving a very specific problem. We're not going to solve with Khalid and others. We're not solving all problems so far. So we narrowed down to very specific, which is really pertinent to the health system in England. So we want to identify mentions of self-harm in clinical notes. Of course, there are specialized questionnaires that could be used for self-harm assessment, like but usually the health system in the UK and Australia as well, which is different from the US one. In England, clinicians usually do not start giving lots of specialized questionnaires to people. When a patient comes to see a psychiatrist starts a dialogue to discuss the problems, and then the doctor writes down a comments. So it is all written in natural language. Some doctors, like in primary care, they may have some questionnaires they may use, but it's not really prevalent. So the problem we want to focus is to how to identify mentions of self-harm in administrative data, which is essentially clinical notes or summaries. So what we did, we started our dialogue with clinicians because we wanted to mimic their behavior, we wanted to learn how to design a automated system to translate clinical knowledge to automated and run clinical notes. So it was all done in a collaboration with clinicians. So we met several times over several iterations. So first of all, we identified, and also it was empirically confirmed by looking at the data itself, that usually clinicians can summarize mention of self-harm in a sentence. So the sentence, it was our unit of text, which we looked at. Basically, we were breaking down the whole document into sentences, and then we've been analyzing. The next thing was how we can mimic the clinical thinking in terms of NLP tools that are available. Clinicians usually they start looking for certain keywords like overdose, deliberate self-harm, a ligature, note, or burning, cutting, and so on and so forth, and which could be captured by an entity recognition task. We also added relation instruction to identify mentions or relations between different entities, and clinicians, and to mimic the way how clinicians decide whether there is a mention or absence of self-harm in this multi-label sentence classification task. So for multi-label, because we want to identify both the presence or absence of self-harm and capture the temporality. The temporality is extremely important for understanding the text. If someone self-harmed yesterday, there is a difference between someone who self-harmed 20 years ago, because we can then intervene, we can act quickly, and then we can change. As you know, as probably the majority of you know, that self-harm, that recent self-harm is the highest risk factor for following self-harms. So if you can capture quickly people, help them, you can significantly improve their outcomes in the future. And what we did next, so then our team, we started doing pretty much following the standard, well-established steps that have been discussed previously by the other people. We took Bergkamp because it simply performs quite nicely. We didn't show Bart because it was good enough for us as well. We tried to be pragmatic, exactly. So here the point was not to develop the top state-of-the-art news tools that go to new reps email, but rather be a really pragmatic, something which works really well for clinical advice. So we just fine-tuned and did a bit of a domain adaptation to capture so the tokenizing effects. It will be captured nicely. And then we ask clinicians to annotate an initial sample of data. So here I'm speaking about multi-level sentence classification because the anti-recognition task usually is a lot simpler, and especially if you use a hybrid approach where you have an ontology of keywords, you can mix them, and usually the token classification task is way easier. So I will only focus on a multi-level sentence classification. So we asked clinicians to annotate the initial sample, we trained a baseline model, and then we got into this improvement loop where we developed a custom interface. It was a web-based Facebook REST API, where the clinicians, they sat down in front of the computer and the computer were presenting predictions of the model. So it would literally like a sentence, like he just cut his arm yesterday, and the model was presenting later. And clinicians should have clicked on confirm or change. It was a part of the kind of active learning approach. So we did it here in this loop. And after several iterations, it's still work in progress, by the way, but then clinicians realized actually it's not bad. So those of you who work with a data annotation, so you can understand there is a massive trade-off between how many samples you can annotate, how much you should pay to your annotators to do the job, and the delta of improvement you can achieve. So when we reach the viewed sample, and these are the preliminary results of the model. So this is for just remind you, for multi-label sentence classification, whether there is a presence or absence of self-harm, as well as a temporality of self-harm. So, and I haven't discussed the irrelevant label. I will make it clear in just a second. So for self-harm, we've got a recall over 90%, which is not bad. It means we're capturing over 90% of cases. Precision was a bit poor because of so those who work with the real print data can understand how dirty and noisy it is to get. Lots of time we can get thousands and thousands of examples to converge. So it's still work in progress. For temporality, we've got poor results, which is not surprising because it's way easier to identify presence or absence of samples rather than to capture the temporality. And I will show several examples just to justify the reason why this is tricky. So these are different examples. So these are all totally made up examples, which are based on real clinical notes. So the first one, the model directly with these are short sentences. So for example, voices were telling him to jump off the bridge, and the model correctly identified as NOSH stands for no self-harm. There is no self-harm because there is no actual act of self-harm. So it could be voices, it could be so we don't know for sure when we jump off the bridge. Here the model did it incorrectly, so the model thought it is unknown. Unknown stands for the category which captures whether it is impossible to determine whether it is self-harm or not. So it's kind of the gray area. So the model is correct because obviously there is no self-harm. So we're only discussing the actual thoughts of self-harm. So this is an intent, it's not actual. And here it's another example where the model did correctly with both labels. So it was on self-harm as well, because she has engaged several times and turned out to run mixed ligature with intent to take her life. So it means that she has been doing for a period of time. Also, so this is why the model put with temporality unknown. So it is not recent and it is not in the past. It could be it is ongoing, but it also is quite difficult to decide from this short sentence. So clinicians agree that these predictions were correct. And here is a bit a larger multiple sentence. It mimics a short snippet from info notes. And so I have 4 sentences. And if you run through the model, this is what we get. And here the label of irrelevant becomes quite fine. So we wanted to filter out sentences that are irrelevant or they completely do not contain any information about self-harm. Like I saw a cat, or for example, today I saw this gentleman presenting with depression. There is no information about self-harm. So we tried different methods to filter out. So we use sentence similarity as well, and so on and so forth. And then we just tried to include. So essentially, what we did, we prepared lots of sentences that have been chosen not to contain any information about self-harm. And then we trained in this category as well. Apparently, the model was quite good. So the first sentence was designated as a relevant, and the second sentence was predicted correctly. So the both labels, it is essentially self-harm. It is an ongoing self-harm, and also the time is recent, because despite the fact that he has been harming since age 17, this is an ongoing process as well. The third, of course, is incorrect, and it was correctly identified as no self-harm, because first of all, we're talking about a family member, not the person itself, and also there is the fact of suicide rather not a self-harm. However, when I played the model, I tried to tweak to see the sensitivity to tokens. So what do if we change a little bit? And interestingly, the model, so if I ended like cutting his beans, we already see that the probability, so the model was not certain about whether it's self-harm or not. So just decided to put unknown, and also probability for being unknown, it's not really high. It's like only 80%. And also the model was calculating between, say, with self-harm as well. Of course, it depends on the threshold, because the word cutting usually statistically was associated with self-harming behavior. So we have certain keywords like burning, ligature, and they like taking, not to trigger the audience. So there are certain keywords that are really strongly associated with the annotated labels of self-harm. And in some cases, model can overfit to these words. And this is a really great challenge I'm going to discuss in my next slide about what kind of challenges we've seen. So first of all, we've hit lots of challenges. And it's a really tricky one because self-harm is usually comes with other cases such as suicidality and the other behaviors which we need to disambiguate, which is a big, and of course, we cannot sit down and annotate thousands of examples like ImageNet folks have done for millions of examples. This is why we're having such great accuracy of distinguishing cats, dogs, and airplanes. So we can't afford the help. So we need to be creative. So the first of all is how to aggregate predicted labels per sentence. If you have a clinical note, like a typical summary with 20, 50, 100 sentences, how do you make your final decision verified? Whether there's a person. It's a question because obviously you will have contradicting sentences, you will have different temporalities. How do you think? So what we agreed with the Dr. Guillaume and the clinician, so if there is at least one mention of recent self-harm, we would regard the whole note as containing recent case, because this is how clinicians usually do. So clinicians usually start describing history, past events, and so forth, but also they will highlight that it's essentially someone self-harmed yesterday or a week ago, he or she may be admitted to a hospital due to self-harm. So at least we have one case, one signal with regard to the whole document as having self-harm. Second, whether the annotation scheme we developed or the way how we try to make clinical thinking was good enough to capture exactly what we want. What are the edge cases? How do we capture what we do not capture? So we've done quite a lot of analysis and we've checked as well. So, and also those who work with annotation and implementation, you know that the annotation schema, it's not written in stone, it's something really kind of a live document which you will iteratively improve over time, because when you get a bit more and more experience and understanding of the matter. Second is, which I already showed, it's token sensitivity. In some cases, it is the right thing to do. In some cases, just simple model overfitting. And we need to disambiguate and understand sometimes that there are real words that are associated with poor outcomes that may enhance, for example, the weights. We can check the weights of each word. We can run all sorts of, we can check the weights of transformers or like sharp values or any explainability methods. In some cases, the token sensitivity is a bad thing, so we can introduce noise or, for example, like back translation or like people doing vision, so you introduce, kind of augmentation, so we can do as well to reduce, but it should be done in a controlled pattern. And of course, how do we evaluate the system? What's the right metric to evaluate the system? whether it is NLP-based metric, whether how do you capture, what's your precision for multiplication of token, whether do you capture the span boundaries surface of text correctly, or rather, if you may not care about the NLP side, but if you're able to identify all people who self-harmed and you identify correctly, probably this is the right metric. So it's very iterative process. You need to understand what exactly you are developing. So with clinicians, we are discussing, and I believe I have 4 minutes left just to show something that I really should just try to stay, but well, it was a bit of a spoiler. And of course, now we live in in the era of large language models, and you can rightfully ask, why bother? Why we need to learn classic? This is what I put like kind of classic NLP cases. You don't need to read the book of Chris Money. You don't need to watch these courses on YouTube. You can just go directly to ChatGPT or GPT-4 and run everything exactly as guys. You brilliantly touch on this point. So I just want to reiterate. So what I did, I took exactly this sentence about I'm sorry, I think you can't see it, but it was exactly this snippet I showed previously. The snippet, I actually plugged it into the GPT-4 and subscription, and I asked a very, very simple prompt without any tweaking. Identify if there is an actual mention of some harm in the text. And if you read the response of ChatGPT, and I showed it to colleagues and to clinicians, and they have been really surprised to the extent the GPT was able to correctly identify. It not only identified correctly, it also explained why it was correct. So it's just identified. It's interesting. So despite that the person has a history, which indicates ongoing behavior, not just past years. This is exactly how elite or public self-harm searchers would have approached these questions. So there is a massive yes.
Can you show again this slide?
Yes. Sorry, yeah. You mean this text? Yes, so it says, so has a history of self-harm since age 17, which he's occasionally doing. This is a typical language used by clinicians in notes. And the ChatGPT was able to do it nicely. The problem is we can't do it. We can't send data. If you remember, there was, I think it was the poll, or there was another chatbot got into troubles on talk therapy a year ago, something, Cooler Health or something. So they developed interface and the talk therapy, but essentially they're using OpenAI API to send. I think they haven't explained it properly in their consent form. There was some problem. They just didn't touch on, which is the right thing to do. You can't just lie to clients. And interestingly, so of course, there is a massive promise of language models. And what I found, it was published by a few weeks ago in mid-March by a team of German researchers. What they did, they just took Llama 2 model and they trained, because obviously this is what they're saying, we cannot use external resources like Claude, Gemini, or GPT, OpenAI. Even with Microsoft Azure, I think Microsoft is doing really great. Not advertising, so I'm not getting wrong. Selfishly, I really want to use GPT-4, but we're still not here. And so what people did, so they did just Llama 2, they fine-tuned, they did prompt engineering with chain of thoughts, and a bit of pretty much standard tweaks, and they achieved a really decent accuracy, 87% to detect suicidality, and sensitivity at 83 and specificity at 91, which I think is a really great result and clearly demonstrated the promise of large language models. But well, Llama 2 is not, I don't remember exactly which Llama version. Now we have a Jamba, and other just came out recently with like massive contextual window length we can use. And this just clearly represents the promise of large language models in the future, as long as we can ensure the patient safety and data governance procedures. Thank you.
Yes, and perhaps could use AWS Bedrock, so with a public cloud, so before.
This is a great point. So, where I work, so the National Health Services, they have they work with the Microsoft Azure, so all their conditions are Microsoft Azure, and I think it will be problematic to do, but I'm not aware whether you can use problems, whether you can use the same. Obviously, I mean, so once it becomes available, everyone will jump on this possibility.
Can you explain again the need of this classification? Because you said that it's important to understand the temporality,
Yes.
so we can help if something is urgent. But if those are transcriptions of sessions with therapists, then the therapist knows that, like, he can notice it by himself without the need of using the classifier.
Yes, this is correct. So first of all, the main reason is to identify if you want to run a retrospective studies or epidemiological analysis. So for example, we want to understand, so when people self-harm, and if you want to identify it, so for example, we can run it automatically on clinical notes, then we can understand, so how much people self-harm last month. And then you can act. You know, that's absolutely right. If you see someone, like if you're a psychiatrist and you see a patient, you know, say, oh, this self-harm, of course, psychiatrist will refer to the right, but also it will be in notes as well. So this information, yes.
Only for analysis, it's not helping the patients.
Well, sometimes clinicians may not refer immediately. So we can then identify if someone did self-harm within a month, or for example, within several weeks, we can then alert again. So clinicians, you should not think that clinicians will always refer a patient at exactly the same time. So there might be some delays or something as well. But yes, usually, so the main motivation to identify a self-harm and temporality, it is for epidemiological studies and to identify the prevalence and data. And the
So I'm not going to look at whether you have the access to the data to classify on whether a patient would either undergo self-harm or would they have the intervention before that, which was aimed at preventing that. I mean, again, in some cases, somebody might, instead of killing themselves, you have the ambulance or have the treatment, but still in both cases, it's an intervention, which is really the outcome we want to predict. So why not go for that, assuming that you had access to that data and it's a problem.
well, that's exactly what at the moment we don't have access to the data. No, but this is a brilliant question, absolutely. So, however, it is also interesting to understand what kind of treatments people have received or whether there was any response. For example, it could be written in clinical notes that someone who self-harmed then have been prescribed CBT therapy or started on antidepressants, for example. And then you can follow and then you can understand whether there was any effect or not. So you can essentially analyze at scale. But of course, we don't have access to data.
Did you see what type of examples are intended to confuse the model?
Yes, we do. We analyze and see. So, for in some cases, on the first put here, just put some of them. So it is. So when we have a conflicting or a words with opposite meaning. So, for example, like suicide ideation, which is not a self-harm. Also, we have cutting or burning in the same sentence. So the words that they contradict each other in some sense. I'm just trying to think of a good example, like someone heard voices of cutting things, or for example, doing something as well. So these are not actual self-harm, but these are words that usually associate. So if you look at annotated examples, you will see the prevalence of certain keywords that are strongly associated with self-harm. And if you see words that are less strongly annotated, or for example, with no self-harm, and if you see that it depends on the distribution of such word in the sentence, it will be really confusing to the model if we don't have enough data. So what we're trying to do, we're trying to trade off between the lack of high quality data and just to find the trade-off, what we can achieve with fewer results. Yes. Sorry, could you speak up, please?
Yeah. What is the usually people that self-harm, like hurt themselves, you won't see it, it comes in like the decision of the moment, they won't tweet in it or post in it. So usually they won't work on it, and if it's the identify or the clinic, so usually it will be a doctor to talk to them. So I wonder, when do you think, like in which situation is that for tool up?
It's a good question. So this is mostly done for epidemiological analysis to identify cases and relations between what people have done and what they have received. So this is not an online tool which can act upon quickly or refer or triage to certain. Well, if it is the case, by the way, it can do so. For example, if clinicians write, so now it essentially can help clinicians to refer or to suggest certain routes to refer a patient given this information. So, for example, it may refer to which team what mental health specialty the patient may be referred to, given the information provided in the stomach. So if someone who self-harmed and also have been, for example, like eating disorders, self-harming, lost parents, it should also be the tool that can identify this information, can help clinicians triage this patient into kind of a downstream pathways, kind of care pathways. So basically, we have a thought of designing tool with the epidemiological studies in mind. So we want to start identifying the prevalence, associations with self-harm, to find people and whether we can invite clinical trials and see what kind of interventions we make. But also, there is another problem of triaging. So people who self-harm, probably they should be seen by certain specialist teams. So for example, like early intervention psychosis, the eating disorders, so it could be depression or other teams as well. Within mental health, the area, the psychiatry. And this tool potentially can help based on the contextual information in clinical law, the way how a psychiatrist summarized the course. I'm not sure if my answer was right.
I just think if a doctor see it, this is their specialty, people know.
Well, in ideal world, it's absolutely.
Want to say it?
No, that's fine. I just want to thank everyone for questions.
We will take a short break now, and after that, we will have a panel. At the end of the panel, we might understand if the LLM is going to replace psychiatry also. Thank you.